Yeah, I can't see myself on it. Bennett has the flu. Well, he's like on the mend. But I said I thought he needed to stay home one more day just to like rest. I'm sobbing. But so like he's fine to go back to school, but what is that? Like, no, threw a fit. Didn't throw a fit, but was crying. Like he didn't throw a fit, but crying. But I think he's mad. Like he hasn't seen his friends in days. You know, all friends on Sunday. I had swabbed him that morning, but it was too early, you know.
Right there. Check, check, check. As long as you see that light, you're good.
Heather, can you guys hear me?
Good morning. I can hear you.
Good morning, Julie. How are you?
I'm good. It's springtime almost and
It is.
vacation time.
It is. It's crazy.
And
I can hear everybody.
Hey, Josh. Okay.
Yeah, we can hear you.
Oh, great. Great. How many's in the room there?
Four.
Nice. Nice. Well, I'm gonna have to jump off at right about 8:30. So if Heather, you want to start? Or you want me to?
You can.
Okay. Good morning, everybody. It's 8 a.m. 8:01. We'll call the meeting to order. Um, as always, protocol updates never comes off the list. Jeremy, are you online? Anybody other than we have some new business from Aaron Grant, medical control call line. I've reached out to Dr. Jackson regarding this. Nick had brought this up again. They were struggling to get through and they were calling just directly to the ER. So is anybody having issues with this, Julie, up in your area?
yeah, it used to be that it was kind of a rare occurrence, but now we have more issues than we have answers. So
Okay.
we're starting to see a backward swing from that.
Okay. All right. We'll get on that. Hopefully we'll get that fixed or handled here shortly. I apologize for everybody for that.
Very sorry, I'm in the room. This is Dr. Jackson.
Oh, sorry, Dr. Jackson.
That's okay. I'm not sure what the issue is. Because there's been instances where we use this Ring Central app, and there's been instances where I've gotten a call from one of the medics, and they mentioned that they had just tried to call me like 40 minutes prior, and I don't have any missed calls. And like my phone was on and everything. I'm not sure what the issue is. I've reached out to the Vituity representative that handles the Ring Central partnership, and it sounds like they're trying to switch services to use actually the Microsoft Teams as the function for the call tree. So more on this to come. I'm aware of the issue and I'm trying to address it as best I can. The other issue is that Dr. Worley's, I think, account from Ring Central got deactivated somehow. So whenever previously we had it so that those calls were going to him as a second line. And I guess when they're not going to me, they're just going straight through to the Union ED's line. So a lot of issues there. I appreciate it, you guys trying to use it, and I'm sorry it's not working out. I'm gonna try to get it back together to where it was so that it's actually useful because I don't want you guys wasting any time in those instances. So just appreciate you guys. I'm sorry, but we're gonna get it fixed. It's just gonna take more time.
Well, that's fine. I appreciate you looking into it and getting on top of it. And if there's something additional that I could do, let me know. Then if the Teams thing, if there's anything that the services need to do different, we'll just figure that out. So
Yeah, I'm hoping it's just gonna be the same number so that we don't have to switch anything, but we may need new numbers. We'll see.
okay, all right, works. Anybody have anything else on that they'd like to bring up or talk about?
I guess for now, we should probably just have crews call the ER directly.
Yeah, I think that's probably best, honestly.
Yeah.
Until we figure out what the problem is.
Yeah, that was going to make a suggestion also, so that's a great idea. You okay with that, Julie?
I've been telling my people to call the medical control hotline, and if nobody picks up or if they get put on hold, to just hang up and call the ER that they're transporting to, since we go to so many different ERs.
Right, right. So for now, we'll just call the ERs direct for now, and then when we get it all switched away, we can go back to the call tree.
Okay, so they call whatever ER they're, just to clarify, they're to call whichever ER they're transporting to, correct?
That is correct.
Okay.
Yeah, I mean they're going to be the receiving hospital. That'd be no, yeah, that's what I would think that's the right way to go.
I do know some of our crews that are transporting into Illinois or even up near Lafayette, they sometimes have issues. So they'll call down to Terre Haute, which I
Mm-hmm.
told them is fine because they're on totally different protocols in that area. So they don't understand what we're doing.
Sure, absolutely. And I was going to make a suggestion that I guess good common sense, right? Make a decision based on what you feel is the best for you at that moment. So,
Yeah.
all right. Okay, good. Thank you. Thank you again, Dr. Jackson. Aaron, you brought this up. I'd love to see you talk about what you'd like to do.
Yeah, so we as far as the IV Tylenol being added for the pain side, we've had a great experience with it so far up in Park. We've had a few people that have worked at some other similarly rural agencies that have febrile emergency protocols for adults as well that include IV Tylenol, all the way down to 2 years old, I believe, is what it is.
Okay.
Um, and I know in ours, as far as the adult side, I don't think we directly even have really like a febrile emergency protocol per se for adults. You know, it's not nearly as dangerous as it is for kids. So I was just going to see how everybody felt about maybe adding the IV Tylenol as an indication for fevers as well.
I see. Dr. Jackson?
I mean, I have no problem with adding IV Tylenol. The reason why we don't use it at Union it's been cost prohibitive.
Hmm.
So that's the only issue. Otherwise, we all know it's a safe drug. So be happy to support that. We just need to make sure that we're getting the dosing correct, uh, especially in pediatrics. But you're talking about just for adults right now.
Yeah, that was my experience. I hadn't looked too deep into the pediatric side. Just suppositories and or the oral Tylenol work pretty well for that side. Um, a lot of times we don't get an IV access on some of the younger kids, so I was
That
specifically talking about the adult population for now.
I'd be in full support.
Good.
Very good.
Okay. Aaron, do you have is there any kind of protocols out there that we could draw from to add to ours to add for the
Yes,
fever?
so I will get that and forward it off to you guys, and we can have a conversation about that, see what that looks like. I don't have it on hand this second, but I
Oh,
will.
that's not a problem. Yeah. I was just going to suggest if you could send it to the group, and we'll get it in front of Zach and Phil and let them tweak it however they would like, and we can get it to Jeremy and get it added in there. So
Yep, I will do that in the next day or two.
that's perfect. Go ahead with your other one.
I was just sifting through the EMS commission meetings from back in November, and I saw that they had all approved the lidocaine for IO starts at the advanced EMT level, and we have a
For
few.
the conscious patient.
Yes, yep. And so we
Mhm.
have a few, advanced EMTs that have worked alone that have had to do it, and so we're just seeing where everybody stands if that's something that we can add.
This
Again,
would be, I don't know what the protocol is actually for that because I've honestly never had to do it. Are you
Mhm.
talking about like a sub-Q lidocaine injection or before the
No,
IO, or is it in the IO kit?
go, Aaron, you want to answer? Or you want me
Yeah.
to?
So after you start the IO, I believe ours is you give 40 of lidocaine through the IO, and that's supposed to help the pain from pushing stuff through it. Is the main
It's
thing.
basically numbs it, so to speak. That so instead of flushing it with saline, you're flushing it with 40 of lidocaine.
Right. Okay. I think I just have to look up the dosing protocol for that, but I'm sure that you guys have it right, so I'd support that.
Right. So, and that was I didn't I thought it's either 20 or 40. I couldn't remember, Aaron, but yeah, I knew it had to be. It was right there in that
Yeah.
area. So,
Yep.
it's just your normal lidocaine, and you put it in there and you flush it so that you're blowing that marrow out of the way, and you're also numbing that area so they don't feel because these people are still awake. So the pain
Yeah,
isn't the drilling, the pain is the fluid going through.
that
And
makes sense.
I personally don't have a problem with it if I mean, they're pushing first round cardiac drugs and everything else. So adding this to as a tool for them is not a bad thing. And I know it was approved because I listened to that meeting.
Yeah, I'd be okay with it. We just need to nail down the exact dose that's
Yeah.
appropriate.
Yeah, it will just it's just basically adding an advanced EMT to that protocol instead of just medic is what that amounts to. And then they'll have to, go over it. But we can definitely look it up and I'll pull that one out for you within the week or so, Doc, and let you look at it.
Sounds good.
Okay. Aaron, does that sound good to you?
Yes, sir. Thank you for the time.
Julie, you got anything?
Sorry, I couldn't get my phone to work. E-Bridge, is that being repaired or looked into? We've had several instances now where I've had employees that say they've sent an E-Bridge and it shows sent on their phone, but they never get the acknowledgement like
Well,
they're supposed to, and then the ER says they're not receiving it either.
okay. So I went in and made sure after that email that you sent me, I went in and made sure it was logged in and everything was fine. I got the eBridge. Also, I keep mine signed out, but then I go in and check them out and acknowledge them. I don't know why they're saying they're not getting it, and I mean I haven't seen them come through. We are working on that and the potential for LifeNet. So we're figuring out the tweaks and trying to get that fixed, Julie. At worst case scenario, if you've got a 12 lead and you're thinking STEMI, you can always take a picture of it and text it to the charge nurse as a workaround until we get it completely fixed and up and running. We are in the process. It has been approved to upgrade our CarePoint to 3.0, and it has more capabilities with the eBridge and makes it easier for the connection. So, but that's going to be a bit when the merger came, that kind of went on hold for a while. So we're in the process of trying to reset that up through IT and get it going.
Okay.
Does a charge nurse have a business phone?
Yeah,
Can we get that phone number put into the protocols?
Yeah, let's do that.
yeah, absolutely.
Yeah, because I don't think it is, and I think that's definitely something that
Well,
would
it's
be.
probably not in the protocols, but yeah, it definitely we can put it right in there. So
Yeah, and what it's like an iPhone, isn't it?
Yeah.
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 It literally sits on the desk right next to the iHeart. So,
Yeah.
and it's
And that's not going to be any kind of HIPAA violation, correct? Since it's not encrypted.
No, it shouldn't be because there's no PI. That's just a picture of a 12 lead with no name or anything on it.
Okay.
I mean, but if you do send HIPAA stuff, it would be a HIPAA violation.
Oh,
So,
absolutely.
yeah, so don't do that.
Well,
Yeah.
I was just asking because I know we've had issues in the past where, if we don't send patient information and cardiologist information and things like that, they don't activate cath lab prior to us getting there and them obtaining their own 12 leads. So
That's a
trying to
good
figure
point.
out the best way to do that if all we can send is a 12 lead.
Yeah.
Right.
well, so
And
we
we're not always in an area where we can call to give that information.
Sure.
so we should be activating off of the 12 lead. If it's a slam dunk STEMI without patient information, we should still be activating. Now, it's always helpful to get that information, so please try to call it as soon as you can, obviously, and I know that there's issues with connection, but that shouldn't be the case. So like if you guys have a STEMI and you text it to the charger's phone, sorry, this is a STEMI or this is our ETA, we should be activating. We don't need I mean, ultimately need the cardiologist to be able to figure out which one needs to come in, especially in the middle of the night, but like getting the rest of the staff early and prepared, helps cut down on door to balloon time. So we're working on that on the physician side of things. Really don't understand what holdup is. STEMI is a STEMI. So if you get any pushback on that, I would like to get some case examples. So please reach out to me via email or text, and I'll start working on it on my end.
Gabby.
Okay.
Sounds good. Thank you.
Get that number sent out just to the group, this group. I'll send the email out with just the phone number alone, and then I'll get Jeremy to get it put into the protocols.
Yeah, we have that reference call
Yeah.
sheet on the protocols in the back. Yeah, add it there.
Right. We'll get it added to there so you guys know if you have it, and then you can all put it in your phones or whatever the case is. So,
Cool.
and Nick, just so you know, in the process of getting a quote for LifeNet, don't know if it's going to go through, but I just want to let you know I haven't let that go. I'm trying to see if we can get that figured out. So,
I love that, Barry. You couldn't
yeah.
see me, but some parts of the stuff you were saying, I put a thumbs down to, and other parts I put a thumbs up to.
Well, okay. Well, I appreciate it. I
You're
appreciate the
welcome.
thumbs up. I get a thumbs up every now and then. That's always makes me feel better. Yeah. I usually mess something up somewhere down the line. Trust me. So we'll just we'll figure it out and we'll move forward one way or the other. So
Awesome.
nothing else. Anybody have anything additional with other business? Anyone?
I have one quick thing.
Sure.
Our minimum stock quantity for mag sulfate, in the protocol is 10 grams. And I was wondering if there would be any way that could be adjusted or why it was at that number. Maybe we could drop it down a little bit because we have a lot of waste with that. So
Hmm.
I don't know if we can drop it down to like 5 or 6 grams.
I think 6 would be fine. 6 is like the max dose you would give for eclampsia.
Yeah.
So,
I know. I mean, I was looking at it as well. I mean, the concentrations we usually get is usually in 5 milligrams, though. So if we did it to 6,
Yeah,
we'd
we'd be
still
getting
need
2
2.
grams.
You guys have been getting 2 grams, and just have. Okay. I mean, I don't care. I'm cool with it. Yeah.
So we could put it at 6 grams instead of the 10. That'd be all right.
I'm fine with that.
Okay.
I did
So
have
you're
one.
gonna you want to change the max dose?
The minimum quantity stock.
Okay, to 6. Okay.
Be the 6 from 10.
The
Okay.
dose would be the same.
Right. I misunderstood what you were saying. So yeah. Okay, that's fine. I'm just trying to make a note so I can put it in the minutes. So
One more thing about STEMIs. We were talking to Brooke Thomas, our STEMI or chest pain coordinator, and she's going through all of our hospital board protocols and guidelines because we're up for reaccreditation this year. And the process of care for EMS arrival for STEMIs, we need to just slightly adjust. And the issue that we need to just like kind of put in there is that if the cath lab is available and ready for the patient to directly transport the patient on the EMS cart to the cath lab. So they may do like a quick stop like we do for strokes before going to the CT, but they need to stay on the EMS cart and go straight to the cath lab if the cath lab is available. So hopefully once we get eBridge better figured out and maybe the lifelines and we get this or the charge nurse phone and we get these STEMIs earlier, this may be more of an active operation where we have patients on the cart and we have the cath lab ready for them right when you guys arrive. But I want to actually put that in our little flow sheet here, so I'm going to do that. And then one little tidbit of this is that I just kind of reviewed the protocol for STEMIs, and I think in our protocol we currently have, if chest pain and systolic blood pressure is greater than 100 millimeters mercury, administer nitroglycerin 0.4 sublingual or nitroglycerin spray every 5 minutes until relieved. I honestly, and I don't know if Zach is on the call, but my personal
he's in China.
Oh, okay, yeah. Well, that's okay. Hopefully he's having a good time in China. I mean, my personal practice is in the ER. If someone has a systolic blood pressure of like 106, I'm not giving them nitroglycerin. So I would feel uncomfortable having you guys do that in the field too, where you have like less resources to address, hypotension. So I think I'd feel more comfortable moving that number to a systolic of 120 as a minimum.
Okay. I know you and I had the offline conversation about that. It's the protocols are set whatever you want, Dr. Jackson. So if you wanted at 120, then that's what we'll do.
Yeah, I'm just saying, like, I'm open to feedback there if anyone has any other opinions on that. I just want to make sure we're safe, and I think I'd feel more comfortable with that if you guys are okay with it.
Yeah, I'm fine with that. I think the general consensus.
I've always kind of operated around the 110, 120. I always thought 100 was a little on the lower side for my comfort.
Okay.
It
Yeah.
is, but I will reiterate, as I told you before, that is literally a nyctosis. That's what's taught in EMT class when you're doing pharmacology. It says 100 or below. So I have no problem with changing it. I mean, really don't. I like the idea. I mean, I think it's safer for everybody out in the field. I just want you to know that that number 100 isn't arbitrary. It's actually taught that way.
Yeah. So that's, a little problematic, and, our fresh EMTs will have to kind of relearn that. But I think it seems like most of the experienced folks have all had, a case where they've probably given nitroglycerin to someone with a blood pressure of like 110 and regretted it. So
Sure, it's very easy to do. Trust me. Yeah,
yeah.
Yeah.
yeah. So we want to change that to 120, and everybody's okay with that.
It'll just be one of those things that I teach in EMT school where I say, here's what it says in the book, but that's not real life, Barry.
Exactly, and that's it.
Ain't
And
no
we do
biggie.
that all the time. I know
Yeah.
Julie teaches stuff up there too. So
Yeah, ain't no biggie.
okay, we'll make that change, and I'll get Jeremy on that too. So
Be busy.
anything else?
Barry, I have a question for you.
Yes.
On your guys' IV pumps, with it being hospital and everything, uh, can we drop off regional pumps at Union or Union pumps at regional, or do they have to go to the hospital that says?
That'll have to be a question I find out the answer to, Jason. I don't know the answer to that question.
Okay, I'm just trying to get everything with them being like,
Nope.
because there's
I
different
appreciate it.
sides. So,
I'll double check with Dave Shearer and get back with you.
all right, thank you, sir.
No problem. Anybody got anything else?
No, sir.
Okay. Well, then we'll probably call this meeting to adjourn, and you all enjoy the rest of your day. I'm going to be out for a leadership retreat, so I'll be out for the rest of the day. Text me if you need something. I can always step out if I have to. So
Have fun.
Thank you.
cool. See you guys later.
Bye.
See ya.
Big leadership. She was so mad. She was just like, you know, I'm professional. You look right now.
Okay, it started. So. Get started with some old business. The medical control line. Still having some issues with it. Dr. Jackson, do you want to talk about?
Yeah, so we're about to switch to Teams Voice. It was previously through Ring Central. For whatever reason, I'm still having a lot of issues with Ring Central, even though it's supposed to be active. There's been times where I've been told by medics that they've tried calling the number like literally like 40 minutes prior to like me seeing them. I have no missed calls. So for now, we were just talking about this, but I think we should direct everyone to just call the ER that you're planning to transport to for medical control until we figure this out. This emailed IT people to hopefully get the call tree back up and running with Teams Voice. I think it's going to take a little bit of time here. So for now, I think we got to go through the most reliable medical control, which is probably the ER that you're transporting to. I apologize. I know it's been a nightmare talking on for lately, and I don't know what the issue is. Emailed them multiple times and can't seem to come up with a solution right now. It's workable. Any questions or anything?
Sure.
Sounds good.
Sorry, guys.
Any other old business? Yes. Give me a report. Working. Morning, everyone. So for our STEMI cases this time, the first one's gonna come from Sullivan. This is kind of an interesting case. So SCAT was dispatched emergently. They didn't know what the trouble was, but the caller hung up before they could get the information. So they tried to call back. They finally pinged the phone and found an address in Shelburne. They found the patient. He said he was fine. He didn't need help. Kind of acted like everything was fine. It was an accident. But then he told staff, "Oh, I'm gonna have these spasms in my chest." They got they were able to get a 4 lead on him just to see, and there was some definite concerns for STEMI. So they talked to him and said, "Hey, guy, you got a bad situation going on," and he was like, "No, I'm fine. So they stayed with him for like 15 minutes and kind of sat with him and talked to him about what was going on. He finally agreed to let him get a 12 lead. There was definitely some elevation with some reciprocal changes. They got him to go to the ED. He had 100% thrombotic occlusion in his mid segment of the LAD. They successfully did a mechanical thrombectomy and stent. He was taken to ICU and incidentally had a coach stroke. It's okay. You want me to hit? Do you want me to hit that when it happens? I'll let people in. Yeah. Anyway, he was taken to ICU. Unfortunately, the following day he had a stroke. And I'm not going to take that fire away from Beth. She can tell that story, but he had an acute thrombotic event in his MCA. So he got transferred to St. Vincent. Unfortunately, I don't know what happened to him after that, but in these cases, we talk about times and goals and, we want to hit those goal times for best practice. But I think in this case, it's important to really point out, like, they took the time, which I think obviously all of you would, but we get kind of wrapped up in meeting those goals, but really I think this was an important case because had they not, somebody probably would have found him dead, unfortunately. And I don't know what his outcome was. It may not have been great, but at least they kind of avoided that situation. So nice work. There's the run history. Again, goal times, we're not going to meet him. He did get to the cath lab from Union's door to reperfusion was under that 90. First medical contact to balloon was 150 minutes. But again, we're okay with that because they did a great job getting him what he needed. So I don't know where the EKG went. I couldn't find the EMS EKG. They don't always get the chart, so that's the best I could come up with. There's the Union ED EKG. And then there's his heart cath. It's kind of hard to see. The two vessels kind of twist, but you can tell in the second picture there's restored blood flow. So they did a thrombectomy and a stent there. course, highlights are that they stayed with them, they called the STEMI alert. Door to, or first medical contact to balloon wasn't met, but we're not too concerned with that because they did a great job here. So nice job. Our second case comes from Hart County. EMS was called out for chest pain. They found a patient laying on the couch who was clutching her chest, reporting a 10 out of 10 chest pain. Started about an hour before she called for help. They did the EKG, showed the STEMI. They got the aspirin and nitro given to her, called in the IHERN to Union ED. They got cath lab activated and cardiology called prior to the patient getting here. Once she got here, she became very hypoxic, very, very much in distress. It was to the point where her oxygen sats dropped because she was holding her breath. They ended up repeating that EKG just to make sure there wasn't something else going on. Cath lab was already on their way. Once they got here, they took her to the cath lab, found 100% occlusion in that left circumflex that was successfully stented. They also found a 90% in her right coronary artery. Plans for a staged intervention on that one at a later time. She was taken to ICU, stable condition, discharged 2 days later. So run times, those were all great. All the goal times were met there. Union door to balloon is 55. First medical contact to reperfusion was 80. So under the 90 goal. There's the EKG. It's kind of hard to see, but it's pretty clear there.
She's fine.
And then there's the one they did here. So classic. There is her cath. You can see that total occlusion and the successful stent. I didn't get the RCA picture on there. I'm sorry. But this was the culprit lesion. So this is what I put on there. So first medical contact to reperfusion was 80 minutes. So nice job on that one. Everybody good. Anybody have any questions? Okay. Thank you so much.
You're okay. Good morning. So we have 2 case studies this morning. The first one, you can see the times here. Everything looks good for the most part, besides the on-scene time. Jackie likes those to be at 10 minutes. But other than that, total run time was 60 minutes. It was way out in the county. This patient was taken to Union Hospital Regional. Initially, they were dispatched for fall with possible broken hip. So it was ground level fall. She landed on that right side. She did hit her head on a shelving unit as she went down, and she was on aspirin. So when EMS got there, fire was there. They were trying to get a pelvic binder on her. She refused to C-collar. She did have shortening of that right leg. If she had been brought here, she would have met level 2 trauma activation criteria, just because the aspirin and the head injury hitting that going down. EMS, she was vitally stable. They did apply the binder. They were able to check fetal pulse afterwards. Cardiac monitor, IV, they did have to dose her twice en route for pain because she was having significant pain is what the report said. They transferred her to Union Regional, and it was not in the narrative, but it was documented that that was the patient's choice. There was no documentation anywhere that said that a conversation was had that an orthopedic service was not available there. So they worked her up. CT head was negative. Lab work was unremarkable. They documented that she was NPO already from earlier in that day, and then she would remain NPO afterwards. And then they identified the right femoral neck fracture. So the NP that took care of her there requested admission here with hospitalist team, and she was admitted with ortho consult. So this is just the transfer. I thought the times on that were decent. I think the call to the hospitalist, it was documented at like 15:19, and then EMS didn't get dispatched for the transfer until almost 2 hours later. So there is some delay there. So she was admitted, taken to the OR the next morning. She had right hemi hip for the displaced femoral neck fracture. She also had a previous hip surgery on the opposite side as well. She did really well during surgery, remained stable. They took her back to the medical floor that she came from. Weight bearing is tolerated. They started PT and OT, started DVT prophylaxis. Patient and family requested referral be sent to regional to MRU. She was accepted there and she remained stable. Lab work stayed good the entire time. And she was transferred there on post-op day 3. I do think the family probably urged EMS to take her to regional because it's documented that the daughter-in-law worked in the MRU at regional. So I'm sure that there was some urge from them to take to regional initially, but since those services are not available there, I was really looking for kind of a note saying that like, hey, we had this discussion, family adamant on going to this other facility. Second case study, this was within the city, so this was a quicker turnaround. This was an MVA, a moped was rear-ended. So dispatch 1 minute, dispatch to en route 1 minute, and then on scene within 5 minutes. And then they departed the scene within 11 minutes, so quite a bit better. So a 26-year-old male was driver of a moped, struck from behind, no helmet. The EMS report said vehicle at unknown speed, but then the IHERN later said rear-ended at 30 to 40 miles per hour. So ish, somewhere in there. Patient did not have full recall of the event, complaining of left-sided pain. And this patient admitted to smoking some meth earlier this morning, which typical Terre Haute. Vitally stable for EMS, got IV access, put him on the monitor. Said he was alert and oriented, abrasion to the top of the head with no active bleeding, tenderness to the back of the head with some swelling. And it did say in the narrative, does not complain of neck pain, but so they did not place a C-collar on this patient. Left chest, ribs, tender palpation. So this did meet level 2 criteria for us. So that was activated pre-hospital, which is what we like to see. They did report, the physician documented that it was questionable LOC. And then upon assessment here, he did have pain with movement. But it was not worse with palpation. So they did apply a C-collar here and then just some generalized tenderness. CBC and chemistry, unremarkable. ETOH was negative. They did not do a urine drug screen on this patient. They did CT head, chest, abdomen, pelvis, and then x-ray of the left knee and I think femur. Those were all negative. CT of the C-spine. Fracture of the right lamina of C6, right pedicle and posterior aspect of the right vertebral canal, C6, fracture of the right lamina of C1, fracture of right lamina of C2. Then they also did further imaging, CTA of the head and neck, and they determined that there was no vascular compromise there. So this patient was transferred to St. Vincent after consult, and then transferred out BLS. I tried to get some follow-up on this patient and I have not got an email back. But I can see where he was discharged and they've been like trying to arrange follow-up appointments, but I don't know like what interventions and what the full meal workup ended up being. So. Questions?
No. I don't know. All right. My name's Dennis. I'm the outreach coordinator for the Burn Center. Appreciate you guys having me in. So if you guys just have any questions, just let me know. So what we're going to talk about today is we're going to go in regards to burns. So we're going to go over the primary survey. Secondary survey, we'll go over fluid resuscitation. We'll talk about how to determine burn depth, and we'll talk about different types of burns and kind of what you do with each of them. And then we'll go over some skin grafting in the end. So primary survey is going to be your ABCs. You guys know all that. So with burns, the big thing is to determine with their airway if they need to be intubated. So what you're going to kind of look for in regards to that is, are they in any respiratory distress? Are they having a stridor? Are they hypoxic? Are they using accessory muscles to breathe? Do they have any blistering edema in their oropharynx? Deep facial burns would be indication of the need to intubate, as well as burns to the neck, especially if there's potential. And then whether or not their injury happened in an enclosed space, as opposed to like out in a field throwing gasoline on a fire. So with inhalation injury, the injuries to the respiratory tract caused by inhaling these things, either smoke, heat, certain chemicals, steam, those can all cause an inhalation injury. Inhalation injuries are about 12.8% of our burn admissions, and they make up about 72.5% of all burn deaths have some sort of inhalation component to them. So different ways to classify inhalation injury. So there's the upper airway, which is an inflammatory. It's supraglottic, which means it's above the vocal cords. So that's the upper airway injury. And then there's a lower airway injury. That's also inflammatory, and that's subglottic or below the vocal cords. And then there's also inhalation injury with systemic poisoning, and we're going to talk about two of those are going to be carbon monoxide and cyanide. So again, the supraglottic injury, which is above the vocal cords, it's the most common, usually from direct heat. You can see some edema, and it can be severe. And certain signs that you're going to look out for: oral burns, soot, coughing, wheezing, changes in voice. Subglottic injury again is the below the vocal cords, usually not from heat. It's usually a chemical type injury. That's injury to the lining of your lungs, and it causes sloughing of the epithelial lining. Typically a delayed response. A lot of times in the initial chest x-ray, and a subglottic injury is going to be fairly normal. Again, it's going to be about 24 to 48 hours post-injury when you're going to start seeing that. To diagnose that is through a bronchoscopy. What you're looking for is carbonaceous sputum, erythema, looking for edema, soot, increased mucus secretions. Okay. And then these are the types of airway injuries. So it goes anywhere from no airway injury, so you're going to see nice pink lungs in that one, all the way down to grade 4, which is a massive injury. And I've got some actual burn patients with some of their bronchoscopies here in just a minute. Talking about carbon monoxide, it's a colorless, odorless gas. It's one of the leading causes of death and fires. What happens is that there's a decreased oxygen delivery caused by the carbon monoxide. And then these are some of the symptoms that you're going to see. Patients can be dizzy. They can have weakness, headaches, nausea, vomiting, difficult breathing. They can become confused, blurred vision. And then ultimately, if exposed to large amounts of carbon monoxide, they can become unconscious. So the carbon monoxide level is measured by a carboxyhemoglobin. And then if you look as that carboxyhemoglobin increases, you have an increase in symptoms. So typically less than 10 smokers kind of live right around that zone. So anything greater than 10 is going to be an indication of possible carbon monoxide poisoning. So you go from a slight headache in the sub 20, and then all the way up to greater than 50, you can have seizures. They can become unconscious, and they can lead to death. We typically don't see that when they come to us, because usually people are intubated and 100%. So our carboxyhemoglobins, when we get them at Eskenazi, are usually fairly low. So the treatment for this is, if they're not going to be intubated, then you want to put them on 100% oxygen until they're symptom free. And usually that's between 4 to 5 hours. And the reason why is because the half-life on room air is 4 hours. And then if you put them on 100% oxygen, that decreases down to 1. So every hour on 100% oxygen, your carboxyhemoglobin is cut. Cyanide is another one. So that's a highly toxic chemical that inhibits cellular growth or cellular respiration. Sorry. It's you get it from the combustion of synthetic materials, all that stuff that burns inside a house fire is potential cyanide. And typically it's in an enclosed space. And what happens is the cyanide binds to the iron ion. It leads to halt in the production of ATP, which is your body's primary source of energy. That and the accumulation of toxic metabolites will cause the cell to die. And here's some symptoms of cyanide poisoning. So you can read those. Weakness, so since there's no ATP production, shortness of breath, that kind of stuff. Some of the antidotes you can give patients if you think that they're have been exposed to cyanide are some of these things which we don't give. Sodium nitrite or amyl nitrite binds to the cyanide. It allows the mitochondria to resume their function because it's binding with that. Sodium thiosulfate, it converts the cyanide into thiocyanate, and that gets excreted in the urine. But typically what we use, I don't know if you guys use this, we use a cyano kit. And we give those to patients that have been in an enclosed space or intubated. So we treat them for suspected cyanide poisoning. Basically, the cyano kit is hydroxycobalamin, which is a form of vitamin B12. It binds to the cyanide and excretes that in the urine, and it's generally considered safe. So what happens is for adults, you're going to give one kit. Sometimes we've given two. And then for pediatric patients, they get 70 milligrams per kilogram over 5 minutes. And the most common side effect to that is this crematuria, which is what you're seeing here. So it turns so that it binds to the cyanide and then it gets screened in the urine. And it turns your urine kind of this wine, deep red color. Some of the other things that you can get are hypertension, erythema, rash, nausea, and headaches. But typically when we give them at Eskenazi, they're going to be intubated, so we don't see a lot of these. And then they're burned, so we don't really see a rash sometimes, but usually it's just crematuria, and then we do see some. So here's some couple patients. I don't know why it's doing that, but so this guy was a house fire. Unclear. We got reports that he had set himself on fire, pour gasoline and set himself on fire. This happened last year in November. He was a total of 70% total body surface area, mostly full thickness, as you can see in this picture. This is taken down in our ED. So he had burns his head, neck, chest, abdomen, back, his arms, and his legs. History of asthma and schizophrenia. He was intubated at the scene. Carboxyhemoglobin that we got was 2.6 at 11:33. You can see he was intubated on 100%. So this carboxyhemoglobin was 3 hours post-injury. So you know that the half-life of the carbon dioxide is 1 hour. So it's 3 hours post-injury. So that's probably why his carboxyhemoglobin was low. Arrived to us by flight to Eskenazi. And this is his initial bronch. So he was a grade 4 inhalation injury, so pretty bad inhalation injury. We also do serobronchoscopy, so every like 3 to 5 days we'll get another bronch, and that kind of helps us determine when the patient's about going to be ready to extubate. So he was rebronched a few days later. And his inhalation injury had improved. He was downgraded to a grade 2 inhalation injury. So kind of a little bit about his hospital course. He had 5 OR procedures. He ended up getting ARDS and then what required ECMO. So he was transferred to St. Vincent's for a few days to be placed on ECMO. He also had an acute kidney injury and then stopped peeing and then had to be placed on dialysis at the bedside. Also had these. He was 70% burned, so he had ended up getting quite a bit of infection. And then also had a DVT. And then eventually became hypotensive, required multiple pressors. We did have a family meeting. So about a month after his initial injury, he was made a DNR by the family and then transitioned to comfort care day after that. So cardiac time of death for him was 12:14 at 5:17. So it was a pretty big burn, so 70%, and then did have an inhalation injury. So this guy, the next two people are kind of just examples of airway injuries. This guy was a younger guy. He was 28, apartment fire, self-extricated and then ran back into the apartment to get a few things. So was inside the apartment fire for probably about 10 minutes or so. Came to us in the ED, and this was a picture taken in his room. So maintained his airway from the scene to the ED up to his room, and we were rounding on him, and he started to have respiratory distress, and then was intubated at the bedside up in the burn unit. This was his injury, grade 3 inhalation injury. So intubated at the bedside, young, healthy though. So he was extubated 5 days later. Day after extubation, was weaned room air and then discharged to home a couple days later after that. So total of 9 days. Inhalation injury. I don't have his other bronch, but he was downgraded to grade 1 or 2 a few days after that. And that's why we're able to extubate him fairly quickly. This guy, you guess what he did? Yes, he was out having a good time drinking, and the fire wasn't burning fast enough, so he threw gasoline. And so I put this picture on. So the other guy, his burns weren't as bad, but he was inside a structure. Whereas this guy, his facial burns are worse than the other guy, but this was out in a field. So quick exposure to flame. He was never intubated, maintained his airway. He was only with us for a few days. We did local wound care and then taught him how to treat his burns at home, and then was discharged. So young, healthy, just quick exposure. So just kind of illustrating the difference between inside and outside for some burns. So this guy, this was somebody we had quite a few years back. He was a farmer. He was on a tractor and it exploded. So he had burns pretty much from his waist all the way up. And I put this picture on to show you the difference from when he came in and then fluid resuscitation. So we give people lots of fluids. And so he also had an inhalation injury, but his intubation was a protection as far as maintaining his airway because of the swelling. So this is on admission right when he got into the ED. And then this is his picture 24 hours after with fluid resuscitation. So it takes about 48 hours or so for the fluids to start resolving. And so then his swelling would go down. But this is kind of how much swelling they get when we do fluid resuscitation on a really big burn. So any questions on that? Okay, so we're gonna kind of shift focus here a little bit on patients smoking on HOMO2. So sometimes it can be an inhalation injury, but typically it's not. It's usually fairly quick exposure and doesn't require intubation. We see about half and half people will come in smoking on O2. Sometimes, a lot of times they'll wait at home and they maintain their airway. But it's about a 50-50% that we get them intubated. Most common complication is COPD exacerbation. So this is a picture of a lady. She was smoking on HOMO2 the day she got in. So we did some wound care on her, and this is what she looked like a few days later. And so she was able to go home with her son the day after this picture was taken. So she was only with us for a few days. So as far as the smoking with HOMO2, just however they present, and then intubate them as needed. So in summary, you want to intubate if there's any signs of obstruction, so hoarseness, stridor, use of accessory muscles, sternal retractions. If they're a large burn, like in that gentleman earlier with the tractor explosion, Large burns will get lots of fluid, so we will often intubate them to protect the airway. Any extensive facial burns, any burns to the mouth, edema, and decreased level of consciousness. If you're not intubating somebody, then you just want to put them on 100% O2 and just continually reassess their airway. Make sure they're having adequate chest movement, any signs of labored breathing, strain, wheezing, hoarse voice, any kind of those, then you want to look to intubate. So once we get that taken care of, circulation, you're going to assess the skin color, heart rate, that kind of stuff. Tachycardia and large burns is fairly normal. So it's kind of a general stress response. So we tolerate heart rates of 120 or less. We consider fairly normal for a burn that's going to be 20% or greater. If they are greater than 120, then you want to look at if they're trauma, any hypovolemia, make sure they're adequately oxygenating themselves, and then assess for pain or anxiety, and maybe hopefully that will resolve their heart rate. But when they come to us, 120 or less, and then a few days later, if they're continue to be tachycardic, then we'll maybe start some metoprolol or propranolol for them as well. Circulation, you want to establish 2 large bore IVs if they're greater than 20%. Get them wherever you can. And then there's always, if you can't get something in, then you can put in an IO. But there's a lot, sometimes with the big burns, if you have to go through burn skin, then that's where you have to go. And then we'll get something more secure, like a central line when they come to us. As far as pre-hospital fluids, you guys don't necessarily need to do Parkland formula, but if you kind of, when you strip them down and look at how much they're burned, if they clearly exceed 20%, then these are the fluids that the ABA has told us to start them on. So if they're 5 years or younger, you're going to start them at 125 of LR per hour. 6 to 12 is going to be 250, and then 13 and older will be 500. And then once they come to the ED, then we'll do an actual Parkland formula, put them on their adjusted fluid rates. But so that for ease for you guys, you don't have to like do math out when you're doing other stuff. If they clearly exceed 20%, then you're going to put them on those fluids. Just make sure that you let us know how much they got prior to coming into ED. So considerations for circumferential burns. There's a potential for compartment syndrome, but that's really something that we look at when they get to us. It's a delayed response. It's usually when we're starting to give them all the fluids for fluid resuscitation. And what we'll do is we'll closely monitor the 5 Ps. And what we're looking for is the need for an escharotomy or a fasciotomy, depending how significant that burn is. So as far as the 5 Ps are concerned, you're looking at pain. So is the pain severe and out of proportion to what you're seeing as for their burn? Paresthesia, so it's that kind of pins and needles. If they're feeling pallor, you look at the color of their skin. So if it's starting to get a dusky kind of pale color, or if their capillary fill is starting to decrease, that's something you want to look out for. Paralysis, so this is kind of a late sign, and it can be an indication of nerve and muscle damage and pulselessness. So that's a critical sign of severely restricted blood flow and the need for escharotomies. We used to do this, like when I worked nights, we would do all these, and then inevitably it would happen like 3 in the morning, the surgeon would come in and need to do escharotomies. So a lot of times for the full thickness circumferential burns, we'll do escharotomies preemptively because a lot of times they're going to need this full thickness burns anyway, so they're going to have to debride all that skin. So some examples of some escharotomies. This is the tractor guy that we saw earlier. He had a circumferential burn to both his arms and his chest, and so he was starting to have peak airway pressure and not getting his volumes on his vent, and so we did escharotomies on his chest, and that kind of relieved that pressure. And escharotomies of the leg, kind of the same thing. It's all full thickness burn injury. And then, so the next one's going to be disciplinary neurological deficits. You're going to use the AVPU method. So are they alert? Are they responding to verbal commands? Are they only responding to painful stimuli, or are they unresponsive? You just got to figure out why and treat that. So for some exposure, you kind of want to remove any loose, dirty debris, clothing, jewelry. If they have contact lenses and they have a facial burn, you want to remove that. And then if any clothing is adherent, a lot of times we'll just ask you to kind of cut around that. Don't try and pull that off. We'll take that off when they get to the burn center. You're going to briefly assess their burn. So if they're greater than 20%, you're going to put them on those pre-hospital fluids. Otherwise, you're just going to put on maintenance, or you can just wait till they get to us to give them fluids if it's a small burn. For small burns less than 5%, you want to briefly irrigate with tepid or cool water. Don't apply any ice or cold water. It can potentially cause vasoconstriction and end up causing the burn to be deeper. You don't need to debride or bandage these burns at the scene. Just kind of cover them loosely with either clean sheet or some gauze, and then elevate in extremities to reduce edema. For larger burns, the big thing with those is you want to prevent hypothermia, so avoid any wet dressings and just put the kind of a burn sheet or whatever you have in your EMS vehicle, and then if you can, increase the temperature, and then try and infuse warm fluids if possible. Once you get through the primary survey, you're going to go to the secondary survey. That's kind of when you're going to take their history. You're going to do a head-to-toe exam. You're going to try to find the circumstances of the injury, their medical history. They're going to update your tetanus, and then any child immunizations if they're pediatric patients. You're going to get, at this point, you're going to get any x-rays, labs. If they're intubated, you want to get an EBG and a carboxyhemoglobin if you're thinking that they've been exposed to carbon monoxide. Electrical injuries, we'll talk about this in a little bit, but we'll, again, EKG, you get cardiac markers, and then you'll get a urine myoglobin just to assess if there's any muscle damage. For pain management, gold standard is IV administration. You want to avoid IM just because with all the fluid shifts on the burn, they can, absorption of those medications can be a little tricky. Give them small frequent doses. If we're going to start fluid resuscitation at this point, and then a couple things that we need before we start fluid resuscitation. We need the weight of the patient. We need to determine how big his burn is. And then we'll have to figure out which Parkland formula to use. So to figure out a total body surface, you can use a couple different ways. The rule of palms is really good for small scattered burns. And so it's the palm of the patient, and that is 1%. And then if it's a bigger burn, we're going to use a rule of 9. So this is the rule of 9 for the adult. So head is 9, your chest and abdomen is 18, and your whole back is 18. Each arm is 9. So the front arm is 4.5, and the back of the arm is 4.5. And then the legs are 18. So the front of the leg is 9, the back of the leg is 9. And then the kids are a little different. Their heads are much bigger in relation to their body. So instead of it being 9, infants is 18%, and their legs are smaller. So instead of 18 on the adult, it's 14 on the kid. As far as fluid resuscitation, it's going to be on any burns greater than 20%. The reason why is because we want to maintain tissue perfusion and organ function. We're going to use lactated ringers, and the reason why is because it's more physiological, close to human plasma, and we give so much fluids. It has a little less fluorine than normal saline, and so large volumes of normal saline can lead to kind of these chlorine metabolic acidosis. And then LR, the lactate is converted to bicarbonate in the liver. It just kind of helps with correcting that. Again, your fluid resuscitation fluids pre-hospital are going to be 125 for a 5 and less, 6 to 12 is 250, and then greater than 13 is going to be 500. So how much are we going to give? So the Parkland form is a 24-hour fluid requirements based on these 4 factors: age, the type of burn, how big their burn is and how much they weigh in kilograms. So here are the formulas that we're going to use. So if it's a thermochemical injury in an adult, it's going to be a factor of 2. Kids generally need a little bit more fluid per their body weight, so their factor is 3. And then for all electrical injuries, we're going to use a factor of 4, just because with electrical injury potential for internal muscle damage, we're just going to give more fluids to help flush those kidneys to kind of protect them. So these are the formulas that we would use during your secondary survey for burn resuscitation. Okay, so here's an example of this. This guy is a 51-year-old white male who was filling his lawnmower with gasoline while smoking, and that caused it to explode. So EMS intubated him and transferred him from an outside hospital to the burn center. He's got these burn injuries to his face, chest, left arm, right arm, so his left arm, and the dorsum of his hand and back. Did not include his buttocks. So here's some pictures of his burns. So obviously greater than 20%. So we're gonna put him at 500 milliliters LR from the scene, and then once he gets to the ED, we can strip him down and kind of figure out his TBSA. So once we do that, his face, we gave him a 2. It was just part of his chest. So that was 4. His abdomen, we about 3%. His whole back, kind of upper back, minus his buttocks. So we gave him 13. His left upper extremity was 7, and his left knee was 1, because it was just the dorsum of that, not the palmar side. So adding those all up, he's a total of 30% total body surface area, and then we weighed him, and he's 101 kilos. So finding the formula, it's going to be he's an adult and it was a thermal burn, so we're going to use this top formula, factor 2. So using that, we'll plug in our numbers: 2 milliliters times 101 kilos times the 30%. And then we divide it by 16, and that gives us our initial fluid rate of 379 milliliters per hour. And then we're going to insert a Foley, and we're going to adjust basically fluids up and down based on how much urine he makes per hour, and then his vital signs and that kind of stuff. So we'll use that, and then every hour we'll adjust this initial fluid rate up and down based on how he responds. This is his initial bronchoscopy. So he was intubated at the scene or at the outside hospital, but he ended up having a grade 0, so no inhalation injury. So we extubated him a few days later. So here's his hospital course. He was admitted on 6/8. Parkland calculation was a little over 6,000 milliliters for that 24 hours. What he actually got was a little bit more. He did 6,639 milliliters. Admitted on 6/8, he had grade 0, so no inhalation injury. Extubated the next day, was room air after that. Only had 1 surgery, and we'll talk about autografting. We're still here towards the end, but 6/11 was his surgery, and then he was discharged home actually a few days after that. So admitted, 30% burn, Parkland resuscitation. He really did very well. He was discharged on the 13th at home, so pretty good. And this is some pictures of him in our clinic. So his burns really were like partial, so they weren't very bad. So he healed really well. Any questions on that? So talking about how deep somebody's burn is, we'll talk about some burn depth. So how to determine that is determined by the type of burn, how long your skin is attached to that heat source, the thickness of the skin. So the skin on your palms and your feet are thicker than obviously on your face, so that'll determine how deep a burn ends up being. The blood's supplied to that area. And then a lot of times the burn care you get directly after the injury. A lot of times the people wait at home, their burns convert to a deeper burn, and then sometimes they have infection. So getting burn care soon after the injury can help with all of that. So here's some burn depth classification. Superficial is 1st degree. And then we have break down degree into superficial and deep partial, and then full thickness, and we'll talk about each of those. So a superficial burn is epidermal only injury. We don't use this, can be red. It's usually pretty painful. Looks like a bad sunburn. We don't include this. So when you're bringing somebody to us, if it's a superficial burn, we don't include that in their TBSA just because it's injuries only to the epidermis. You don't get a lot of fluid leak from that. So that's why we don't include it in their TBSA, because we're not adding that to their fluid loss. So this is just an example. This lady was out by a bonfire and somebody threw something in and flashed and got her face. The next one's going to be partial thickness burn. So this is deeper into the dermis. It's going to have blistering. It's going to be moist and painful. The big thing with this is going to blanch very easily. So it's really good blood flow. It's kind of an example of partial thickness burn. So you can see it's nice and pink. This guy had his lawnmower explode on him. So we kept him for a few days because after the explosion, he kind of rolled around in the dirt. So we just want to make sure that his wounds were good. And then we kept for a couple of days, and then we taught him how to do wound care, and then he got discharged home. Just another example of a partial thickness burn. This lady threw gasoline on a fire and flashed back behind it. I put this because very rarely do we get women that throw things on fire.
What are you trying to say?
Just try to point that out.
Yeah, I found that funny. And so a deep partial thickness burn, this is second degree also, but it's going to be deeper into that dermal layer. It's still going to be painful. Oftentimes you can see hair follicles can be cherry red, and then the deeper ones can be pale and mottled. And this is, if you have blanching, it can be very slowly blanching. So this is kind of an example of a deep partial thickness burn. You can see the hair follicles, those little pinpricks. And then how this heals, if we don't do surgery on this guy, it'll heal from the edges and from those hair follicles. And then the full thickness injury, it's injury through all the layers. So you guys know what this is. It's kind of dark or dry, hard and leathery. You don't have any surface sensation. And so this is a burn that we got several years ago. This guy was wheelchair bound and for whatever reason decided he wanted to burn trash in his yard, and then got a little too close to the fire and then caught his pant leg on fire. He couldn't get out. His sister had to hose him down with a garden hose before EMS got there. So this is another picture of his leg. So this is all full thickness burn injury down here. And then this is like deep partial. And this is another guy. He was an elderly gentleman. He was burning leaves in the fall, and then accidentally caught a shirt sleeve on fire. So this is all full thickness burn injury right there along that. So different types of burns. So thermal burns that we see the majority of, they're about half of our admissions. Those are burns from flame heat, flashing, like when you throw things, explosions. This burn, we had her recently. She woke up too close to a space heater.
Oh
So,
gosh.
yeah, so she ended up having, this is all full thickness burn. So we ended up excising all that. She ended up having to have a muscle flap for that upper area, shoulder area. I think she's in rehab now. Chemical burns and X, they're about 5% of what we admit. Those are for acids, alkalines, and organic compounds. For acid burns, again, that pH is going to be less than 7. This is about a quarter of what we see. The majority of the chemical burns we see are alkaline burns. But with acid burns, the injuries from coagulation, necrosis. So what happens is the acid will hit your skin and it forms a hard plaque-like layer. And that layer can limit further injury. But this is kind of an example. This is a hydrochloric acid burn. So you can see where the hydrochloric acid has hit that person's thigh and then how it's run down. And so that forms that plaque-like layer. In contrast, alkaline burns, pH greater than 7, this is the majority of what we see of these type of chemical injuries. Injuries from liquefaction necrosis. And so what happens is that chemical kind of seeps into the skin. There's deeper spread of that chemical. and can continue to cause damage for hours after an injury. This usually happens like with people working with cement. This guy. And so it got on his pant leg and didn't realize it until the next morning when he got up and he was showering and his skin was falling off his. Get that a lot, and they don't realize it until the next day. This one is a plumber, and he got some drain cleaner on his pant leg. And this was him in our clinic that afternoon, so it was a pretty deep, full thickness chemical burn injury. He didn't need to get admitted. We just treated him as an outpatient. He did have to have surgery and grafting on that knee. So the treatment of the chemical burns is one, you never want to neutralize an acid with an alkaline, or vice versa. Try to brush off any dry chemical, and then you want to irrigate the patient with large amounts of cool water, usually about 30 to 60 seconds if possible. And with the bigger exposures, you want to try to avoid hypothermia if you can. It's kind of hard if it's a big burn and you're dousing them with a bunch of water. Hydrofluoric acid is a big consideration for us. So if you get somebody that's hydrofluoric acid, it's really important for us to know. This hydrofluoric acid can be absorbed topically and systemically. What happens is the fluoride binds to electrolytes. It can cause hypocalcemia and hypomagnesemia. So for bigger exposures, we can give calcium gluconate topically or through a drip. So a lot of times we'll get people from Purdue working in the chemistry labs, and they'll get, working in those hoods, they'll get hydrofluoric acid on their hands. And so we'll mix calcium gluconate with hydrogel or something like that, and then apply it topically every 6 hours. And it can be quite painful for these guys too. If you have eye injuries, you want to remove any contact lenses if they have them, and then irrigate them with LR. And if you can use a Morton lens or nasal cane or whatever, get pretty messy when you're irrigating the eyes. Electroburns are next. They're about 3% of our admissions. Small surface wounds can hide pretty devastating internal injuries. Path of the current in the body can be unpredictable. So a lot of electrical burns, you're going to have a thermal component to that. So a lot of times it can be just a flash, where like this guy was working on an electro box, and he actually did not take any current. It was just a flash of the electric. So it's kind of superheat air, and then it could also ignite clothing and superheat metal in the clothing. So you get burns that way. And the electric burns also can be an injury from the current itself. That movement of that current through the body can cause fractures, joint dislocations. It can cause muscle contractures and can also mummify extremities. This is the right hand of a guy who was from the working on one of those big windmills up near Terre Haute, and then he went to go grab a line, and he thought that it power had been turned off, but it hadn't. So this is kind of an example of how electric burn you can get contractures and mummification of the extremity. So we ended up having to amputate that in mid-form, I think. And it also can cause arrhythmias. Electric burns can cause trauma as well. This guy was a motor vehicle crash into a pole, and he ended up having an electrical line lay across him. So yeah, we had to excise all of this. He had some dead injury to some of his ribs. His ribs were injured from that, so we had to remove them. He had pretty big injury there. He did survive, young guy, didn't have an insurance, so we had to keep him till we were able to discharge him home. He's doing well. Skull burns are next. 70% of our admissions you get scalds from water, steam, any other liquids, hot foods, grease. Those are all considered scald injuries. So this lady, her story, she did one of those YouTube challenges where they sprayed her with hot water, and then she came to see us after that. So you get lots of stuff. Skull burns also, this lady is from Greece. She was pulling something out of the oven and it was in one of those aluminum containers that kind of collapsed on itself and then sprayed spill of hot grease from that. So for this one, 130 degrees Fahrenheit, it takes 30 seconds for that degree of water or fluid to cause a full thickness injury. At 140 degrees Fahrenheit is 5 seconds. And at 150 degrees, it takes 1 second to get a full thickness bone injury for that temperature. So for pediatric patients, a lot of those kids are pulling soup out of microwaves or off the stove. And then unfortunately, at Riley, which is where all our pediatric patients go, there are also the abuse components to that. And then for us, we get the elderly people with diabetes soaking their feet, and then pulling their feet out and their skin's falling off. So it's kind of what we see as far as skull burns. Contacts. So this is with hot surface. You ever get a guy like this, just leave him and then send him to us. Because this can take hours to remove all that. So tar, asphalt. This is the same guy, his hands. So we'll use an emollient, irrigate it with cool water to make sure it's cool, and then you can transfer it to us. And then we're going to use either bacitracin, petroleum gel, or mineral oil. And it can take hours to get all that off. So if you remember what that guy's face looks like, that was him. He never got admitted. So this was him in the ED. So it just took them a long time to get that off. So no injury to his, and this is his hands. Asphalt, on the other hand, can be pretty hot to begin with. And so this guy was working for the Department of Transportation, filling all the potholes in the springtime, and he had a syncopal episode and fell into the hole he just filled, and so fell in face and his hand. And then once we debrided his hand, it looked like that. So that's all full thickness. He had to have grafting on his hand. Probably a year or so of OT as well, just because with full thickness burn injuries, especially the fingers and the palm, as the wound heals, a big part of that healing causes contractures. So they need to go through a lot of therapy to kind of help that. And if sometimes it doesn't even work, so we'll have to go back in and do additional surgeries to release some of those joints because of the contractures. Road rashes are next, and so these are treated based on how deep they are. These both are fairly superficial, partial road rash, and so these would just be treated topically, just cleaned up, and then an enzymatic debrider placed on them, BID. For deeper burns, this lady was struck and then drugged by a truck on the road, and so this all looks pretty bad, but this without surgery. When she came back, she was originally a trauma patient and then came back to our burn clinic for treatment of this burn up there. So that's a pretty deep, full thickness road rash. So this one needed a dermal substitute and then grafting. So she had a couple more surgeries to go in, and this all healed pretty well. Frostbite, we just got through frostbite season. And so we probably admitted like 90 patients over the last 3 or 4 months. So frostbite was pretty bad for us. If you guys know what frostbite is, it's when your extremities get cold and you can be insensate. The big thing with frostbite initial care is you want to remove the patient from the cold, remove any wet clothing, use warm blankets, protect any body parts from trauma. You want to elevate the hands and the feet for edema, and then treat their core hypothermia. You want to try to avoid rewarming until you're pretty sure that they're not going to go back into the cold and re-injure themselves. And then if you know the time of injury, we have been using TPA and iloprost to help potentially save fingers and toes. So like right now, we probably wouldn't get any because it's usually the homeless people who just now are starting taking off their shoes and decide that they've got a really stage 4 frostbite. But if we all of a sudden get a really cold snap and somebody comes in, it's really important to get them to us quickly because the TPA and iloprost, they have time limits on when we can use them. So, and that protocol is kind of evolving. We just started using lacrosse this year, and I think we've got some pretty good results. We haven't had to do as many amputations as we did last year, so more to come on that. I put this in because this is kind of how frostbite can progress over several weeks. This guy adamantly refused amputations. So this was him on admission. And this is what this frostbite looked 3 weeks later. So after we shot this picture, he finally did agree to amputation. So we took him to surgery. But you can see clearly the line of demarcation for the frostbite injury. So this is all dead. And then this is probably where we did the transmetatarsal amputation. All right, skin grafts, and then we're done. I put this in here just so you can see how bloody burn surgeries are. We'll debride their wounds down until we get good bleeding like this, and that we know we're in good tissue. This is going to be the same leg for the next few slides. So this guy was burning leaves in the fall, and he caught his pant legs on fire. So his other leg looked like this. So burns to bilateral lower extremities, and his feet were saved for the most part because he had tennis shoes on. That's his feet. So full thickness burn injuries, initial debridement. This is homograft, so cadaver skin. So we'll place this usually first, let the wound bed heal up, revascularize, make sure there's no infection. And then once we're sure that the patient's wound is going to accept their own skin, we'll put autograft on, which is their own skin. And this is post-op day 1 placement of autografting. So the other one was cadaver skin, and then this one is their own skin. And you can see we took the donor from his thigh. So we take the skin off of the donor site area, usually the thigh, the back, abdomen. Occasionally we'll use the scalp as well. And then we'll usually mesh it to cover a bigger area and then place it on their debrided. This was him a few weeks later, and you can see there's some take. This is all autografting, but this guy did have some Pseudomonas infection, and so some of his autograft did not take and fail. So we've had to take him back several times and regraft those areas, debride and regraft. And this is him in clinic. So still, he was really bad diabetic too. I forgot to mention that. So going to be having extended healing time as well. And then this right here, you can see that's actually bone. So we had to do more debridement and then dermal substitute on that and then grafting on top of that. So this guy probably took 8 to 10 months to heal up. He was such a bad diabetic. So just some more grafting. So this is autografting again, meshed. And then this is sheet autografting. So instead of meshing it, we will have her take it from the donor site and place it right on either hands or face. This usually has a better cosmetic outcome and less instances of contractures. So that's another reason why I put it on hands. And then the donor site, this is a typical donor site. So we take the skin off. The instrument's called a dermatome, but it's like a cheese slicer. And so that the surgeon can determine how deep they want the donor site to go. This usually takes about, on a healthy adult, will take about 10 days or so to heal, and then we can reharvest from the same site about 3 or 4 times before the skin gets super thin and not good to regraft. So we can wait, if they're a really big burn, we can wait 10 days or so and then regraft or reharvest from that and apply more grafting. The nice thing that we can also do is resell. So this is a partial thickness burn. This guy was involved in a mobile home fire. It exploded. He jumped out of the window. He was a veteran and had a dog that we allowed him to have in the hospital because he was a therapy dog, I think. Anyway, so this is all partial thickness burn injury. He was 22%, so he also did get fluid resuscitation. But his length of stay was only 5 days, believe it or not. And this is his wound. So his wounds weren't really that deep. He was extubated well. And then we did the RECELL on him, which RECELL, basically what that is, spray on skin. You take a small donor site and then you put it in a solution and you actually spray it on their debrided wounds. And this is him in our clinic. So post 9 days after his surgery, he looked like that. And that's kind of the Superthel. So it's another dressing that goes on top of the spray on skin. And then this is what he looked like 18 days later. He's like completely healed. And then finally, this is the last one. This is the CEA. So any burns that are greater than 50% total body surface area, so over half your body, will take a biopsy. I couldn't think of that word for a second. And we send that to Boston and they grow skin in petri dishes. It's ready in about 2 to 3 weeks. So in the interim, while we're waiting, we're doing debridements and placing homograft and waiting for that skin to be ready. Just kind of pictures from their website. This is what the skin looks like. So it comes in these little petri dishes, and that's a gauze. And then underneath that gauze is your CEAs. It's about 3 epithelial cell layers thick, so it's super thin and very fragile. And so it's kind of a picture of the surgeon picking up. And then this is where the skin is. You can't even see it. And they lay that on the debrided burn. So this guy was a house fire, injured on 3/24. So 4 weeks later or so, we've been debriding him, putting homograft. So this is all homograft. So this is a picture of what his wound bed looked like prior to removing that and getting his wound cleaned up. This is the next day with the CEAs. So these are all the little CEAs on there. And this is him 36 days after that surgery and almost 2 months after his burn injury. And this is him in our clinic. This one's a little bit better. This is one of our first people we did CEAs on. So the pictures here are pretty good. And so you can see the debrided the wound, and these are all the CEAs. I can't remember how much they are now. 5,000 for one of those. They actually fly them from Boston by courier. So a guy gets on a plane, and then they get 2 seats, one for him and one for the CEAs. And it gets hand delivered to the burn center. And this is that guy in the previous picture. It's about 9.5 months after his burn injury. Any questions? I know it's a long time.
CEA stuff is pretty cool.
It is. It's really intensive. They get twice a day dressing changes. The dressings are usually about 2 to 3 hours a piece. They can be one-on-one. When I started, we would paralyze people so they wouldn't move for first. But now they use therapists will splint them, and so there's no movement, and they're not always intubated sometimes.
Is the RECELL, is that are those stem cells that they're?
No, it's actually, we just take a really small donor site and then they prep it in the OR and then take it off the epithelial cells off their the donor site, and then they mix it in a solution and they just literally they just spray it on.
Have you heard anything about stem cells being sprayable at some point?
You know, we had a rep in yesterday, we're talking about stem cells. When I was on the floor 15 years ago, we did have stuff, I forget what it was called, but it was baby foreskin that was, and it came in frozen in cartridges, and then we had to place them. Most places did it in OR, but we did it at bedside for whatever reason. But yeah, there were like, back then, 15 years ago, it was like $2,000 for a cartridge. And we've done a couple of fish skin too. We don't do a lot of that. Any questions? I do have another thing just to let you know. March 20th. Wait, no. May 15th. If you're interested, we have an advanced burn life support class. It's kind of similar to ACLS. But if you're interested in becoming certified, I have federal funding, so it's no cost to you. If you're interested, it's a class that's 8 to 4. Maybe less certified. So you just let me know.
Can you send that to Barry and have Barry send that out? Sweet.
So class is about 18 students per. Then, I mean, for the class that's coming in May, I've already got like 6, so I only got 10 spots left. Cool. All right. Well, thank you. I appreciate it.
Thank you.
Thanks, Dan.
Hopefully, I got something.
Does anybody have anything else?
I see you all the time, and I'm sure.
Is it a month? That is everything for audit review. Here is the QR code. Just have everybody online fill this out, fill out the form. Or thanks, everybody.